There we go. I can see it now.
All right. Sorry, I don't know why it took so long for it to click in. I had to try it a second time. Let me just check. As soon as it comes up, I'll have you test the captions real quick.
Right.
Okay, so Tara, if you would just type something for me. I'm not seeing any captions yet. George, how long do you anticipate this meeting running?
About an hour, maybe hour
Okay.
and a half.
Okay.
I can see the captions on YouTube.
You are seeing the
I can see
captions?
them.
Oh, okay.
Yeah.
All right. Well, I'll keep this on in the background. There you go. Now I'm seeing them. I'll keep this on in the background and just let me know if I can help with something.
Okay. Can you just make me host again?
Oh, sorry.
Joyce? Maybe Joyce need. Yeah, you need to. Okay, perfect. Thank you.
Yep.
All right. Good morning, everybody. This is the training work group of the Alzheimer's Disease and Related Disorders Commission. Apologies for the delay. We were just having a couple of technical hitches. Everything is good. I'm just waiting for Rick to come back in. He popped in and out a couple of times. So we'll just give, here he is. Good morning, Rick. I was just saying we had some technical hitches, so apologies for that. I'll just do the housekeeping announcements, and then I'll turn it over to you, if that's all right. If I can find them. Hold on just a second. Okay. So as I said, this is the training work group of the Alzheimer's Disease and Related Disorders Commission. Due to the active state of emergency, this is an electronic meeting pursuant to item 4-0.01 of the 2020 Appropriation Act. Meeting notice has been provided. The meeting is being recorded and minutes are being taken. All votes will be conducted by a roll call of voting members. Meeting materials have been posted under the Alzheimer's Disease and Related Disorders Commission's quarterly meeting tab at the link posted in the slide. Members of the public are able to live stream this meeting via the DAR's YouTube page. Please be advised that if the live stream is interrupted, we will need to pause the meeting until it is restored. Public comment will be accepted by email or phone to my attention. Public comments that were received by today, May 3rd, will be read, or if lengthy, summarized during the meeting when we reach that agenda item. I'm going to skip the Zoom functions since I know we're all pretty okay with that. But just a reminder to please only use the chat feature if you have a technical issue or other issue that's not related to the business of the meeting, because chat comments are not captured in the live stream or the recording, so they're not available to members of the public. If you have your video enabled, just be aware that your image and video will be captured in the public streaming and recording. If you'd like to view the real-time captioning of today's meeting, please click on the CC button on the menu bar at the bottom and select Show Subtitles. You'll be able to turn on your closed captioning if you're in the meeting, and YouTube streaming will automatically include the captions. For all votes, we'll do a roll call, and you'll be asked to indicate support with an A or a yes, opposition, nay or a no, or abstain. And lastly, I would like to very much thank the DARS video teleconferencing team and the DARS communication team for making this electronic meeting possible. I'll do a roll call of members to confirm attendance. I'll just go alphabetically. Vicki Armstrong, she sent me her regrets. Laura Bowser said she'll be here a bit late. Denise Butler. I see
Sorry.
you, but
I forgot to mute myself. Sorry, I.
Hi. Karen Garner is not here. Rick Jackson.
Here.
Kim Kuttner.
Present.
Chesley Williams.
Here.
Okay, so we do have a quorum, Rick.
Thank you, sir.
I will pull up the agenda and turn it over to you to welcome everybody.
So by now you all should have received a number of items from George via email, the first of which is the agenda for today. You can see that it's a very busy agenda, and if you've gone through the attachments, you know how much material there is. So why don't we start with getting, George, if you will, take a roll call vote to accept the agenda.
So I'll need a motion.
I move we accept the agenda as written.
Okay, thank you. Second, anybody?
I second to move that, to approve the agenda.
Thank you, Denise. Okay, so the motion is to adopt the agenda as presented. Denise Butler.
Yes, I second that.
Okay, you're voting now, so yes or no.
Oh, I'm sorry,
Okay.
sorry. I adopt. Sorry, George.
That's all right. I didn't make that clear. Rick Jackson,
Yes.
Kim Kuttner,
Aye.
Leslie Williams.
Yes.
Great, thank you. So the agenda has been adopted as presented.
Sir, moving to the next item, you will see minutes from the previous meeting that was held February the 3rd that George has sent. I hope you've had a chance to review them. You'll see all that we dealt with, who was there, their votes on the various items, and of course, the something we're going to discuss later today, which would be some efforts for us in the new year. So could I get a motion to accept the minutes, or are there edits, things you'd like to see corrected?
I move we accept the
So, Rick,
minutes.
yeah, if there's no changes, you can simply adopt them. We don't need to have a vote for that.
Okay. Do we need a roll call, George, accepting the minutes?
No, you can adopt them unilaterally.
Okay, so if there's anyone opposed, speak up. Otherwise, we're going to adopt these minutes and move on to the next item. The next item is public comment. George, did we receive any public comment?
We did not, Rick.
Thank you very much. So guys, next on the agenda is the review. I spent some time looking at it this morning, and it was very, very impressive. I'm very proud. I hope all of you will be very proud as we review this today. These are wonderful, wonderful documents that will serve everyone very well in what our aims are. So we're going to take a look at, I think, the toolkit first, George, or in the brochure.
Yeah, so we're going to kind of do it together, if that's all right.
Sure.
I can't show both at the same time, but just a bit of context for those of you who aren't members of the commission. When Rick lifted these up to the commission on, when was it, March 8th, March 9th, at the commission meeting, we did get quite a bit of feedback centered around, I'd say, two particular points. So one of those was about the diagnosis section, and that was really aimed at clarifying that people should, as a rule, be referred to a specialist for a diagnosis wherever possible. So that rather than relying on the primary care workforce to do the diagnosis, which was sort of implied in those toolkits. So we've changed that. Let's see. I'll start with the brochure because it's a little clearer.
So Denise and Kim, you'll appreciate the change in language you're going to see here, because now when we talk about what happens in primary care when they use the toolkits, it's referred more to as a screening or red flags or signals or reasons for concern, as opposed to a diagnosis. And then, as George said in the meeting at the commission, there was a lot of conversation about going to neurology or a memory care assessment center, a geriatric assessment center, to in fact achieve a diagnosis. And that was indeed important, I think, clarification, and you'll see it.
Right. The
Yeah,
difference
so-
between assessment and actual diagnosing
Yes,
is now distinct.
yes.
Yeah. So what I've done, and you'll see it in both the toolkit and now the brochure, it's just a little easier to see maybe on the brochure first, is give steps. So we have 4 steps, which first one would be dementia screening or cognitive screening, and I want to ask you about the wording for that so that we are consistent across both of these documents. The second, and so that would be using those screening tools like the mini-cog or the slums to decide whether somebody was showing signs of cognitive decline and needed to be referred to a specialist for workup. So then step 2 would be refer for a diagnosis to either a neurologist or a memory clinic. Step 3 would be the practice protocols for follow-up care. So that would be within the primary care clinic setting. And then step 4 would be connecting patients with services and support. So that would be kind of a follow-on from that care plan in step 3. So I hope that it seemed to me when I was looking at the different tasks involved in this, that seemed to be the easiest way to break it down, but I'd be welcome to any other ideas, of course. But in the meantime, I've given those 4 steps, both in the brochure and then in the primary care toolkit on page, I guess as part of that introduction. So step 1, cognitive screening, step 2, referral for diagnosis. And then just a bit of language about primary care physicians are strongly encouraged to refer patients to specialists for diagnosis. Now, I did find, I was looking at other states' offerings in this vein, and I found one from California, which is a really comprehensive guide to cognitive assessment. In fact, it's literally a word-by-word, how to do a cognitive assessment interview with somebody and a historian. very, very detailed. So one of the they did have an explanation for why it was important to ensure that. So Laura Bowser's just joining us, but they did have a short paragraph explaining why it was important to allow diagnostic what's the word? So to allow primary care workers to come up with a diagnosis in cases where it was relatively clear. So, and really to save the very limited specialist workforce for cases that were more complex or where the etiology was really uncertain. So if it was quite clear that it was a case of Alzheimer's disease, then they were willing to let the primary care doctors diagnose that rather than refer on to a specialist. So we've discussed this in this work group before. We know there's a shortage of specialists, and of those 150,000 odd people in Virginia with a diagnosis of Alzheimer's disease alone, or expected to be living with Alzheimer's disease alone, we know there's 100,000 people with the diagnosis, and then another maybe 40, 50,000 people who don't have a diagnosis, or maybe who are not being captured in those Medicare statistics that we've looked at. And not all of those people are going to be able to be seen by a specialist. So I know at UVA, the wait list can be up to, or the waiting time for an initial appointment can be 6 months. So is it fair to the patients who have a fairly clear presentation to make them wait 6 months before they're getting a care plan and follow-up care? So I know this is going to be, this is met with fairly strong opposition by those representing the specialists, but I think we need to make some space to allow the primary care workers to have a say in the diagnosis when it's relatively clear or simple. So I'd really love to hear what you all think, since you're living this day to day. How can we strike an appropriate balance between referring to a specialist as the ideal and recognizing the reality that not everyone is going to be able to be seen by a specialist?
And George, not only is there a shortage of specialists, but if we look across the state and we look in Southwest Virginia or other areas, it's even more pronounced. And you're right, that was a source of much discussion at the last commission meeting. So yes, George and I would love to hear from those of you who are still in the field, your thoughts about this.
This is Kim. So the reality, and that's why we're making this brochure, is when you get the assessment, the initial assessment that leads to the 6-month appointment, that's the time to start looking at resources. While you're waiting, connect with the Alzheimer's Association, your AAA, start gathering, building that A-team that Tina Thomas talks about at the Alzheimer's Association, building that team of who can help, putting a plan in place, whether they have a definitive diagnosis or not. That's a good idea. Denise?
We talk a lot about building a support team. So Tina's concept of the A-team, and I think part of building that team is that team will change as this progresses, and kind of recognizing that it's not just here's your support team. This person may be very good at this point in early stage, but as it progresses into moderate and to later, we need to think about who else what other resources people in the community we need to call on to help support that person. The other thing that is not in here, but it's on my mind a little bit, is when we're talking about supporting the care partner in this, and we talk about being for them on this journey, and I don't know if this is appropriate for this or not, but we need to build something to help support them after their role as a care partner, caregiver has ended. That we don't have, I don't see that we've built anything into this, George. And it's something that's recently kind of been on my mind a little bit. And I just wanted to bring it up in today's meeting to see if this is something we need to be thinking about for this journey for people that are living with dementia and their care partners.
Thanks, Denise.
Absolutely, Denise. Thank you. We certainly talked about that a lot at SEAL. You know, that at some point, the caregiver care partner is likely going to be grieving the loss, and our care for them and our description of the journey should not end at the loss, but assist them with the next phase in their life. Thank you.
You're welcome. Yeah, I not think we're not doing a good job of preparing people for when this role ends. And how do we, because there's so much that goes into this. So I like us to think about that as part of our journey. When the journey's over, there's still a piece there that we can do to be of support to the care partner, to the families.
And I see this document is really helping get that referral, that initial, and getting them connected to support. And then that would be up to the support. So if the Alzheimer's Association locally refers to SEAL, and then we I guess it's the support teams in place that would have to focus on that as well. Laura, from your experience, is this appropriate and feel good moving forward with this? And also the piece afterwards that Denise is talking about, where that fits in?
Yeah, I'm catching up right now with everything. Sorry, I was late, everyone. But no, I agree with everything that you're mentioning.
Yeah, if I may, I think that's a really interesting point. And I'm wondering whether that might, well, I'm wondering two things. What is available now for people whose journey is currently ending or has ended? Well, at least part of their journey has ended as the person they're caring for has died. So are there any support groups for recently bereaved caregivers, or is that something maybe we would encourage the Alzheimer's Association to maybe set up? And could that be virtual so that it could reach all areas of the state rather than being limited to one or two or five geographic areas? And then the other thing I'm wondering is whether that might not be a more appropriate topic for the Dementia Roadmap, which is really aimed at the caregivers.
Yes.
Yeah.
Yes, we don't want to get into their mission creep, but yes.
Yeah. But I think to me, that's all part of the care planning. Because what we see are the care partner, caregiver, that this is all they did. This was their whole life for X number of years. And now they don't have a purpose any longer. And there are grief support groups. I don't know how many are specific for people that were care partners, caregivers for people living with dementia. That would be interesting. I did have a situation a few years back where it was an adult child who was looking for a support group for just adult children, not for spouses. And that's also another thing to be thinking about. Do we need to think about a support group that is more specific for the surviving spouse versus the adult children? Because it is a very different dynamic.
Yeah, I agree. And I know just from the Alzheimer's Association work that I've done, there isn't really anything support group wise that I know. And there's also a bizarre dynamic between men and women when it comes to support groups. A lot of women want to go to support groups and mourn more with feelings, and sometimes men don't feel comfortable going to the support groups. And it's not it's not talked about a lot, but if you look at the statistics, there's a really big hole there. So speaking to the children, I'm wondering if there isn't even just like a women's support group or a men's support group or some kind of, some service.
Hospice. If they have hospice at the end, that's some follow-up. And I don't know about Carol or others who are offering BRI, how long someone individually follows up, but that's only with the care partner, not the whole family who could benefit from support.
This sounds like a wonderful opportunity for research. I don't know where the funding is going to come from, but it seems to me SEAL or UVA or Norfolk State or Hampton would think about conducting research across the state. Are these services available? Where are they? How to use them? And assuming we discover what we already think, which is they are not there, we start talking about what do we do to increase the number of those kinds of specific support groups for people going through the journey with Alzheimer's.
Thanks, Rick. I know Zach, the postdoc working with SEAL with the University of Minnesota's Care to Plan, is studying just that. So we do know folks outside of Virginia studying it, and then the next steps. But looping it in with the roadmap is a good idea. Here we're getting the assessment and diagnosis into the right resources to start their journey, support their journey.
Yeah. So while I think that care planning is very integral to what we're doing here, it is definitely much more focused on care planning for the person living with dementia rather than the caregiver. So it might be, I mean, there is some identification of caregiver issues in a couple of the practice guides, but it's not as explicit as maybe we'd like it to be. So maybe that can be a kind of adjunct step rather than, or we can tweak the language to ensure that caregiver needs are included in that care planning process. But when you think about the Medicare billing codes, for example, then that's really geared to the person with the diagnosis. It's not about care planning for the caregiver. At least that's my understanding. So I want to avoid trying to do too much with this and move away from from making it too diffuse, and so not really serving its purpose well enough, which the purpose really is aimed at facilitating early diagnosis, detection, and care planning.
And George, in all of these things, as we finish it, I think it's always appropriate to say that in doing this, we learned some interesting things for next steps. And maybe that's the language we should put around this issue, is that, yes, for now, we're pretty comfortable with this document. Having said that, look at what we've learned and look at what might be an appropriate pursuit moving forward.
Yeah. And it's interesting. I mean, I know, so for example, there is one support group that I know of where the majority of the folks lost the person that they were caring for I think quite a few years ago, but they continue to meet. And it has become a support group more for people who've already lost their person than for those who are currently caregiving. So I think that you'd find some isolated incidents where these types of supports are available, but they probably aren't advertised at all or marketed like that. So I think having some research would be really fantastic to see what's there and identify the gaps that that we could help fill at some point. But yes, I think that's a good point, Rick, that we see that as the next steps. So I just want to.
Yeah, so are we going to move into
ahead,
the
Rick.
kit next, or the brochure? What, or you said they're together?
Yeah, so I guess my first question is, are there any thoughts of, so this paragraph that you can see on your screen now, the referral for diagnosis, is that enough of a push for ideally referring to specialists while still allowing space for diagnosis within the primary care setting, or should we make that more explicit?
I like the word strongly encouraged. I like the word strongly encouraged. Yeah.
I think it's strong enough.
It doesn't suggest malfeasance if they haven't done it. It's suggested it's strongly encouraged.
Yeah. And then in the, sorry, my menu keeps taking over from.
I recently heard, but don't have the publication link, that eye doctors, some of them have purchased the equipment, that it's just a quick scan of the retina and that's a detection of Alzheimer's. Has anyone heard that? Because they too could now be included with the PCPs. And it's just an assessment, they said. It's not a diagnosis. But they would then need some direction as well.
I haven't heard that, but that would make sense. It's interesting.
I'll share once I get the link.
Yeah, Kim, if you could, that would be great. And, you know, maybe we can have a kind of an abbreviated version of this for eye doctors then who are doing that initial screening. So then what do they do?
And then what?
Are they actually referring people out for follow-up care, or are they just letting people know that that we did the screening and it looks like you might have Alzheimer's disease?
That's terrible. That's worse. Right.
Yeah,
They need this.
Yeah, so, but I think we could have something that's more tailored for them.
Nice. Thank you.
The other kind of main point that came out of the commission meeting was that the toolkit needed some sort of context, and so that's what I've tried to do without making it too detailed. I mean, we want something that people will actually take the time to read, which means not having a 50-page document. So as I said, there's some extremely comprehensive guides out there that we could always refer folks to if they want something that detailed. But we want to make something that, recognizing the time poverty of most workers in a primary care setting, that this is something that they'll actually have time to look at and take in. So I just created a one-page, slightly more than one-page introduction and context setting just about why this is needed, the prevalence of Alzheimer's disease and dementia in Virginia, some information about racial and ethnic disparities, and the Medicare annual wellness visit and why people need to include that cognitive screen, which is meant to be part of it. And then just a little bit about the dementia state plan and how you know, what is ideal care for somebody with dementia in a primary care setting. So, and why we want to encourage early diagnosis. So, as I said, I've broken this down into 4 steps just to group the tools that we have. So, I guess what I'd like to ask about is that context setting appropriate? Do we need more? Did I leave some things out that you think should definitely be included?
I really appreciated paragraph 3 and the differentiation you made as to socioeconomic factors and why minorities were more affected by it. I think that was really important to say that. Thank you.
Mm-hmm. Yeah, as you may know, the Alzheimer's Association's Facts and Figures for 2021 has a whole special section on race and ethnic disparities. So it's a great read if you have time. But I just wanted to highlight, I guess, a key finding I thought from that. So.
On the next page, the members of the commission who were concerned about screening versus diagnosis will appreciate the language change in 1 through 4.
Yeah.
Can we enlarge, zoom in? I want to do this to my screen.
Yeah, I'm like it.
Sorry.
Thank you.
You're welcome. And then the next kind of concrete thing I'd like your feedback on or your thoughts on are the 4 steps. So in this toolkit, this is what I've called them: cognitive screening, referral for diagnosis, follow-up care planning, connecting patients with supports and services. On the brochure, the wording was slightly different, so I adapted the wording that we had previously, but I think we'll pick one so that they're consistent across both. But so, for example, number 1, do you prefer cognitive screening or dementia screening, which was on the brochure?
I think I like cognitive.
Yeah, I like cognitive much better because
Me too.
it's not just memory or dementia, it is cognitive screen. I think that's why all those are really designed just to screen for cognition more than just one aspect.
Yeah.
Is there a word, is this for caregivers and mainstream, like 6th grade reading level and below? Do people know what cognitive means?
So, well, this is aimed at clinicians.
Oh. Then we're good. Thank you.
Yeah. Okay. Step 2, I had referral for diagnosis or just refer for diagnosis. I guess either one of those is maybe refer is a bit more directive than referral.
Maybe referral for evaluation.
I'm going to beg to differ on that one. Yeah.
Yeah.
They,
I think we're assuming that almost sounds like you're expecting a diagnosis.
No, there was a strong distinction made between screening and diagnosis, and this happened at the commission meeting. So an evaluation is beginning in primary care, and what the commissioners wanted was the language of diagnosis to be held for specialists, either a geriatric assessment clinic or neurology. So I think leaving the word diagnosis there is very important.
But refer versus referral.
Yeah. I think refer maybe just because it's a little bit more directive.
Step one.
I think
Step two,
the
refer.
message coming the
Right.
message coming out of the commission was we want to direct people to specialists. Does that sound good to everyone? Yeah. Sorry, I know this is a little bit kind of very fine tuning, but I just want to make sure that when we take this back to the commission that we've met their concerns. So then step 3, I had follow-up care planning here in the toolkit and practice protocols for follow-up care. My thought is to make it follow-up care planning in both. Because it's pretty clear that there are protocols and tools aimed at follow-up care.
That sounds good.
Does that sound okay to everybody?
Yes.
Mhm.
Okay. And then step 4, connecting patients with supports and services, was pretty much identical in both. I'll just have it, connect patients. Maybe connect is better again, like refer. What do you think?
Yeah, I agree. Connect is better than connecting, much
Mhm.
like refer
Yeah.
was better than referral. Yeah.
Okay. All right. So we've got the 4 steps. So I'll make sure that these are changed as well. In terms of just describing these steps, so for cognitive screening, clinicians utilize one of the screening tools available in the toolkit to screen patients at regular intervals, such as during the Medicare annual wellness visit. The toolkit includes several validated screening instruments, instructions for their use, and links to training videos. So again, I want to keep it short and simple, and we can put these steps on the front page of each section in the toolkit as well. So that would be like here, you could put that step 1 again. Which I didn't do on this version, but looking at it, having looked at it a couple more times, I thought that might be a good thing to do as well, just to repeat those sections. So does that sound like a good idea? Okay, I see nodding. So we talked about step 2. Step 3, follow-up care planning. So I just wanted to give an outline of what follow-up care planning should ideally look like, and that was these are the categories that typically show up. So medication therapy and management, maximizing patient abilities. So that could be through physical, speech therapy, things like that. Care partner, caregiver education and support, health and wellness and engagement, home and personal safety, legal planning, and advanced care planning. So we wouldn't necessarily expect the primary care clinician to be covering all of these areas, but these are areas that are using the billing code. It's very prescriptive in what needs to be discussed, and so While I didn't include the full discussion about the billing codes, I included links to both the Alzheimer's Association's, I think it's a 5-page document describing the billing code 93889. Scoot forward to that. So 99783, which is the main care planning guide. I talked about a few of the required elements. So this was another, for Denise and Chesley, this was another point made by the commission that we needed to include the Medicare billing codes to encourage more primary care workers to use these. The National Alzheimer's Disease Resource Center, which is an offshoot of the ACL, has another document that talks about billing for other dementia. It talks about 99783 as well as a number of other billing codes for other activities, which include advanced care planning, evaluation and management, health behavior assessment and intervention, and then a link to that free guide. So I didn't feel like it was worth trying to paraphrase and come up with a completely new version of two very strong documents that are already available. So that was my intent of including some information about them and putting links to them rather than trying to rewrite them. And that this portion would go right at the beginning of the follow-up care planning section, and then followed by the tools. Does that sound like we're meeting the commission's expectations there?
It does for me, George. And Kim, boy, there's another great opportunity for research. I'd love to know how many primary care physicians across the state are doing this. Whether or not they find it helpful, whether or not they consider the reimbursement sufficient to cover their time. I'd love to know the answer to that one.
Sure.
I second that, is that George or Rick? But I have just a little tidbit of following up from that. I have a couple of older family members that are trying to take their one couple basically is the wife has been taking the husband to a primary care physician to try to get him diagnosed with Alzheimer's, which he has most of the symptoms, but the doctor, basically the primary care physician, told the wife that as long as basically he could clothe and feed himself, it seemed like he was okay. So she was really discouraged because she knew that there was more going on, but they're like in their early 80s, they don't use the internet. And so resources like this that are found in doctors' offices, because the doctors are not given the proper information, they're going to have to, go for their own resources by finding these resources, like just around in doctors' offices or wherever they can get them. So with that situation, I was able to find a neurologist in that area for her to take her husband to get formally diagnosed. But this is in southeastern Virginia, where it's a rural area where there's only one neurologist in the city. So, just resources like this are very helpful to be found in doctors' offices because the doctors are not providing all of that information.
And one of our problems and one of our challenges moving forward is when this is all done, what are the mechanisms we get this out to primary care? How are we going to do that? Who are the champions within healthcare systems and within the community, to your point, to make sure primary care has access to this?
Yeah, I think there's two great points there. One, Chesley, I think I'm gonna talk about the Dementia Roadmap, because I think that would be the sort of thing that if people could pick up at their doctor's office would be extremely useful. So while this is kind of a behind the scenes document to help improve their care experience within the primary care setting, that Dementia Roadmap is going to help connect them with supports and services and other things available in the community, and get them thinking about the things that care planning should entail. Hopefully, a doctor's office that has this document, this primary care toolkit, will have started discussing some of those things with them already. And then that Dementia Roadmap is something that the family can take home and have as a resource when they're not sitting in front of their doctor. And then how do we disseminate this? So, I mean, we've talked about that with a number of different things over the years, and I guess one of the things that we should hope to get out of the pilot testing of this would be how primary care, how the pilot sites think that this, how they could have best received that information. So, and where they would have looked to find information similar to this. And I'm sure you all have plenty of ideas about this as well.
Yeah, just kind of thinking back on how I found information to get resources for my mom when we put her in, when she was first diagnosed with dementia. And a lot of it, basically the doctor's offices did not provide a lot of information to help us. It was more so they'll put her on a medication, but that's about it. So as far as like figuring out things on our own, it was a lot of research on our own. I did get some information from like the Southern area on aging. They're good about mailing out information, that those resources were mailed. Other than that, everything else is like a lot of stuff you have to look up on your own.
Sad but true.
Yeah. So I guess, this is one of those gaps that we're hoping will be addressed by this toolkit, is that those doctors will realize that simply prescribing something and saying 6 months, see you at your next appointment, isn't enough for people living with dementia, and that they need to be made aware of what's available in their community, and the primary care setting is a prime place to do that. And so, I think the brochure here and the toolkit are both aimed at helping address that need.
Yeah, I'm wondering if we can't also put this on the site that we're kind of building out as well. Make it downloadable, but should there be a 5-minute video that goes with it that just kind of gives the high level overview for doctors so they know what they're actually looking at, to encourage them to read it. Because there's part of me that says it's not long enough, we're not including enough information. And then there's a part of me that says if it's too long, no one's going to read it. So I'm trying to sort of balance that reality.
Hear, hear.
Yeah, I think that's a fantastic idea. So I was certainly planning on including it in the Dementia Capable Virginia website, but having a primary care doctor or nurse practitioner, or more than one, explaining the value of this and why it's important for other practices to use it would be excellent, I think. Any other thoughts? So I'm just trying to think if there's any other changes I made. So the other thing I realized was that we could actually brand each of these toolkits that formerly were Dementia Friendly America. They have the Dementia Friendly America logo. We can brand them with the Dementia Capable Virginia logo and just note that we've adapted it, as you can see on this page at the very bottom, adapted from Act on Alzheimer's. So we don't need to reference Dementia Friendly America apart from as where those training videos are sitting, which I think will, help raise the profile of Dementia Capable Virginia as part of this effort.
It sounds great. It's looking really great, the formatting and everything.
And then, thanks, Laura. The other thing I did was include the reference section that's in the Dementia Roadmap. So we had talked about having a listing of the area agencies or some way of helping the primary care workers know which or where they should be referring people in their area. So including the whole network would be really helpful. And then there's the other resources from the Dementia Roadmap, which break things down into specific categories. So legal and advanced care planning, more general documents, information on other dementias. So there's a bit more than just what's on the actual tools themselves. And I also went through the tools and where possible put in our local Virginia information. So particularly everywhere that eldercare.gov was mentioned, I changed that to contact your local area agency on aging and provided the DARS 800 number for that. And then any other local resources or statewide resources I included as well. So Virginia Now. So for example, if you look at the bottom of this sorry. So on this is the which document is this? The care coordination practice tool. So in the care plan checklist, we've got, for example, under legal planning, referring to an elder law attorney, and there's the website for the Virginia Elder Law Attorney Organization. Under advanced care planning, we have Honoring Choices Virginia, which has a number of resources for advanced care planning, arranging services and supports. We have the Area Agency on Aging and Virginia Navigator. So I think those will make them more useful and justify branding them as Dementia Capable Virginia adaptations. Does that all sound good, folks?
Looks great.
And again, sorry?
Looks great, George. Very impressive.
So thanks, Rick. Again, the idea of running the pilot is to get as much feedback as we can from those 3 sites. So, or minimum 3 sites, but at least 3 sites is what we've said we'll do to the CBC under the BOLD Act grant. So any other thoughts or comments or ideas about this?
Does this require a vote? Yay, nay?
Yeah, I did not put a vote on the agenda, but yes, it would if we're comfortable sending this back up to the commission.
So I don't know if it's appropriate for me to make the motion because I'm the chair, so I think I'm going to defer to the other guys.
I'm happy to with the changes that we've made today.
I second that motion to approve the amended version.
Okay, so I'll do a roll call. So the motion is to present this the document with the amendments discussed today to the commission at the next meeting on June 8th. So A or nay, please. Laura Bowser.
Yay.
Denise Butler.
Yay.
Rick Jackson.
Yay.
Kim Cutner.
Yay.
Chasley Williams.
Yay.
Okay, so thank you all. The motion has passed, and I'll make those amendments as discussed, and we can present it to the commission on June 8th. And hopefully they'll give us approval to move it on into the pilot stage.
There could be more debate, but hopefully not.
Thank you for everyone's input. Valuable input.
This is great.
Yeah,
And the
I
heartbreaking
definitely
story, Chesley.
Yeah.
I'm sure there'll be more debate at the commission,
Yeah.
but hopefully,
Me too.
hopefully we can. So, I mean, one thing I suspect the strongest pushback we're going to get is around the diagnosis and referring to a specialist. And I think if we can present, not necessarily a united front, but to have some arguments that, in fact, we know that not everybody's going to be able to see a specialist, and that the reality is that some people will end up being diagnosed. In fact, many people will end up being diagnosed or not within the primary setting.
We can always use the word optimal, strategically preferable. I mean, there's many ways to describe that, and we all can endorse that, but we also have to accept the reality that in many cases it's just not going to happen, so.
But there's telehealth as well. So maybe
point.
the primary care physician can set up an area for them to see a telehealth clinic.
Yeah, great point.
Which Carol's now doing.
Yes.
Yeah. And under the BOLD Act, the Alzheimer's Association is helping to push the Project ECHO, which is aimed at helping bring specialists into clinics, in rural or isolated areas. So, like everything else with the BOLD Act grant, it's taking a while to get moving, but once that starts rolling out, I think that will be a really important test to see how well that works, and whether we can rely much more on telehealth for diagnosis. So,
That's great.
all right. Thank you very much for all your input, and I will address all those issues and make the amendments.
So, George, in the interest of time, I'll make my comments on this one very brief. And this is only a suggestion for the training work group as we consider our work moving into the fall of 2021. It's been my experience that often APS workers from the Department of Social Services and CSB workers from the emergency service workers from the CSB find themselves involved in serving the same clients at the same time, and they get crossways with each other in regards to language. An example I'll give you is that the APS workers will say, that the CSB workers will say, dementia is not a psychiatric diagnosis, it's a neurological diagnosis. Consequently, it's not in our area of jurisdiction or expertise. And the APS workers will go, yes, but this person who has dementia also has anxiety or depression or a longstanding thought disorder. And they get funny with each other about who in fact should take responsibility or the lead in serving this client and this family. And what some jurisdictions across the state have done is put together joint task forces of both APS and CSB workers who actually staff cases and train together and stop the finger pointing and understand that what they're really dealing with here is behavior and danger. And so I believe that that is an issue all across the state and something worthy of our looking at to determine in the commission, can we do anything to improve those communications and therefore improve the way the clients and families are dealt with. There's a gentleman that I used to work with many years ago, Dean Barker, who was at Hampton. He's now in Colonial. And Dean probably would be willing to come speak to us about the progress he's seen in those two jurisdictions. And I'd be willing to reach out to Dean to see if he would meet with us. But all this is only a suggestion, and I'm sure there's many other worthy directions for us to go in. I just want to offer it up. Yeah, go ahead.
I was just gonna say, I personally am very interested in studying this and figuring out what we can do to address it, because I know firsthand it's real. When it comes to dementia, oftentimes people have a history of anxiety and or depression, and it's just a reality. And if you get a diagnosis, oftentimes that leads to anxiety and depression. And so I don't personally know anyone that had dementia that didn't have anxiety, depression, or some sort of cognitive other issue. So I feel like this is an area that really needs improvement and focus.
Thank you. It's certainly been my experience. I encountered it in emergency departments. I encountered it when I was at the CSB, and I encountered it when I was at SEAL. And we all talk about it, and we all admit that we could do better. And there are fits and starts in doing better, but I don't believe there's been much progress across the state in doing better. And I think DARS and this commission has a chance to be influential and doing better. So Denise, Chesley, Kim, thoughts? So let me put it this way. If there's no objections, I'll reach out to Dean to see if he'd be willing to attend one of these, our next meetings, and give us some description about what he's seen as a potential model.
Sounds good.
Yeah, I think that would be fantastic.
So no problem. I will do that. Have we picked a date for the next?
We have
not. Yeah.
We have not. But so if you want to, if you'd like to speak with Mr. Barker and see what would be best for him, and then we can try and work around that.
Sure, absolutely. But I'll do that. Yep.
So can I just ask you, would the idea then be that we would work to create some sort of model curriculum for kind of maybe a toolkit like this, or I mean maybe a shorter version that would be aimed at teams of APS and CSB workers? So, or maybe, or have an outline of what a model collaboration could look like, or something like that. Is that what you're thinking?
Yes, exactly.
That we could then share out to CSPs and APS workers around the state.
Yes. And you know, George, I hope that if we go down this road, that we'll all be pleasantly surprised at the number of CSBs and Department of Social Services who are already going down this road. And then it may seem redundant and we can go in another direction. I doubt it, but yes, that's the direction I'm thinking.
Yeah, so I'm wondering, it may be worthwhile, depending on what we learn from Mr. Barker, it may be worthwhile inviting somebody from DBHCS to talk about this, because I know, as we all know, there's plenty of activity and things emerging from the General Assembly and the budget around kind of the later stages of these interactions, which is once somebody's been in a state hospital and looking at discharge planning and things like that. But this could help address some of those issues at the front end. And so just being mindful of the work group that's been set up to look at these issues. We don't want to duplicate what they're doing, but we want to be able to support their efforts and maybe trying to address these issues at a different point. So.
And you know, to that end, George, I will act quickly getting in touch with Dean, because if we discover that there has been success or that we might be duplicating this other group, then obviously we got to come up with some other directions. So I don't want to take forever, so I'll get in touch with him quickly.
Okay, so maybe we can think about meeting sometime in later in June, rather than.
Yes.
I think so. We're now beginning of May, so maybe if you can speak to him sometime in the next couple of weeks, and then we can narrow down some dates towards the end of June, if that works for people.
All right. I'm taking notes. Are there other things for the good of the group or the good of our work that anyone would like to raise as we approach the bewitching hour?
I don't think so.
Hearing none, I'd say this meeting is adjourned.
Great. Thank you all.
Thank you very much, everybody.
Thank you for your leadership, Rick.
My pleasure, as always. Take care.
Bye.
Bye-bye.
Bye.
Bye-bye.